Hello, everyone. My name is Caitlin D. Clerk, and I and my colleague and friend, Dr. Mohammed Garipur, are excited to welcome you to this event. Mohammed and I are the co-founders of the Epidemic Urbanism Initiative, which is hosting today's session and which we're going to introduce in more detail in just a moment. Before we begin, I'd like to start off with just a few notes of thanks. First, of course, our wonderful colleagues who you'll be hearing from in today's panel. And also, of course, to the members of our epidemic urbanism community who are now representing more than 90 countries. So a hearty welcome and thank you to you all. So before we introduce the panel, I just wanted to say a few words about the origin and ongoing work of the initiative as a way to help frame today's conversation. The Epidemic Urbanism Initiative was formed at the start of 2020 when the COVID-19 pandemic began. And this was founded to create a dialogue around issues related to architecture, space, and their relationship to epidemic diseases. And you see here the poster from our first symposium. Since then, we're excited to say that this initiative has grown to include a board of experts, more than 1,800 scholars and professionals who comprise our broad community, and a team of regional liaisons that represent more than 75 countries. Following the publication of a volume on architecture, which you see in the middle of your screen, this volume centers on architecture and urban epidemics. We also have hosted a series of workshops, symposia, and panels, as well as an architecture competition. All of these are archived in our YouTube site, which you can see here on the right side of your screen, as well as on our website. The compilation of all these resources has made the Epidemic Urbanism Initiative now become a didactic hub where scholars and practitioners and others interested in health and architecture can access learning materials and news about events. So this in mind, for those of you who have not had a chance to join our community, we welcome you to sign up for periodic emails that we can send. The bit.ly link is on your screen here. We also invite you to learn more on our website, epidemicurbanism.com. And every single one of the conversations that we've organized or participated in under the auspices of the EUI are available for you to view on our Epidemic Urbanism YouTube channel. So we certainly invite you to visit us there. I also just wanted to let you know that we do have another panel coming up next month. I will share this again at the end of our session today, but we invite you to continue the conversation about health and equity with our panel of global architects who are going to be really thinking about the role of architectural practice in sort of promoting health and equity at a global scale. So all of the efforts that we just talked about now are guided by these principles of our initiative. First, we recognize our shared global vulnerability to epidemic illnesses. And through this initiative, we're really committed to addressing and intervening in these vulnerabilities through the creation of educational resources that are accessible to a global and public audience. And for us, really essential to the spirit of collaboration that we're trying to cultivate and promote is the need to share knowledge and resources, both across disciplines, but also really importantly, across continents as well. We also just wanted to note that since its founding, the purview of the Epidemic Urbanism Initiative has progressed from a focus on epidemics in the city fabric to broader implications of the relationship between health, equity, and the built environment. And I think that's a really nice segue to today's session, which really foregrounds the roles of organizations in addressing the range of timely questions that have been provoked at the intersection of global health, health equity, and the built environment in the wake of COVID-19, and of course, the various vulnerabilities and inequities that it exposed and exacerbated across the world. So now the last thing on my agenda before I hand the mic over to our moderator is just to introduce our panelists for the day. Today's session is moderated by Thomas Fisher, a professor in the School of Architecture, also the director of the Minnesota Design Center and the former dean of the College of Design at the University of Minnesota. One of the most published authors in his field, Tom has written 12 books and over 75 book chapters and over 450 journal articles. He chairs the International Geodesign Collaboration Leadership Group, which is a network of over 200 universities around the world that use GIS as the platform and the SDGs as the metrics to evaluate environmental strategies at the subnational level. His newest book, which you all may be interested in, has been published by Routledge, and it's called Space Structures and Design in a Post-Pandemic World. This volume addresses the impact that pandemics have had on cities in the past and what impacts we might expect in the wake of the COVID-19 pandemic. So very relevant for today's discussion. Tom is also joined by a wonderful panel of experts who I'm delighted to introduce you to now. Giselle Sabag is the executive director of the International Society for Urban Health and a globally recognized urban health leader with 15 years of experience advising governments, multilaterals, NGOs, and private sector companies to develop sustainable, inclusive, and resilient cities that promote and enhance resident health. Prior to joining the International Society for Urban Health, Giselle was a public sector consultant at Bloomberg Associates, where she advised cities on developing evidence-based urban health solutions with the aim of improving the lives of the greatest number of citizens. Previously, she was the vice president of programs at the Center for Active Design, where she oversaw the development, planning, and implementation of innovative Center for Active Design programs, such as FitWell, which was developed in partnership with the US Centers for Disease Control and Prevention, also known as the CDC, to implement design and environmental changes that support healthier workplaces, homes, and communities. Sharmeen Kader is an architectural designer, researcher, and educator. Her project areas focus on healthcare, higher education, and housing environments. Since 2017, she has been serving on the board of directors of the Environmental Design Research Association, and she just finished her role as chair of that board for 2 consecutive years and is now serving on the board as past chair. In her professional life, she is a health and wellness design strategist and has developed her skills in the post-occupancy evaluation, or POE, process. She's developed multiple POE tools, has worked in architectural practice as a lead design researcher, and is now working as a research scholar in the healthcare design program at Kent State University. Throughout her academic and professional life, she has received many awards and recognitions. For example, 3 of her practice-based research projects received EDRA's Certificate of Research Excellence, or CORE, awards. Sharon Rorty is a senior program officer at the Robert Wood Johnson Foundation, where she concentrates on the impact of the built and natural environment on population health, including looking for global exemplars that can be adapted and adopted in the US. She has developed programming initiatives relative to childhood obesity, community development, social isolation, climate change, and sustainable and equitable development. Prior to RWJF, Sharon was the CEO of the National Center for Bicycling and Walking, or NCBW. And in and outside of government organizations, Sharon has comprehensive experience working on transportation, environmental urban policy, and planning initiatives. And finally, Alan Logan is a fellow at the Nova Institute for Health in Baltimore, Maryland. He's a graduate of the State University of New York and the Canadian College of Neuropathic Medicine. For 10 years, he was invited faculty at Harvard Medical School's Benson Henry Institute for Mind-Body Medicine. And here he presented on nutrition and mental health and natural environments. He contributed to the Natural Environments Initiative at Harvard School of Public Health, and also is a co-author within the Oxford Textbook of Nature and Public Health from 2018 Oxford University Press. Alan has been published in over 24 diverse scientific and medical journals, from aquatic biosystems and beneficial microbes to Lancet Psychiatry and Pathophysiology. He's published extensively on the history of science and medicine, twice winning the Japanese Society of Physiological Anthropology's Research Award for Excellence. He's the author of Your Brain on Nature from HarperCollins 2012 and The Secret Life of Your Microbiome from New Society in 2017. As you can see, we are in for quite a wonderful and robust conversation today. So with that, I would be delighted to turn the mic over to you, Tom.
Great, good. Thank you, Caitlin, and thank you everyone for coming to this webinar. As Caitlin mentioned, my work has been looking at the impact that pandemics have had on the built environment. And one of the things that they all reveal are the inequities often that exist in existing systems. We saw this in the 19th century with the cholera epidemics that revealed the inadequate water infrastructure that we had in many cities and really prompted and accelerated the installation of the kind of infrastructure that we now take for granted in many parts of the world, indoor plumbing, storm sewer, sanitary sewers, and what have you, although still we have parts of the world that do not even have that basic water infrastructure. And so these are long-term effects of these pandemics. We saw this as well in the 1918 influenza pandemic, where it revealed the overcrowded housing conditions that were prompting the spread of that viral disease and led to a lot of reforms in housing and zoning codes, building codes that we now still are putting in place. And again, there are still parts of the world that do not have those sort of basic safety measures. So pandemics reveal inequities, and they also accelerate change. And so I think the opportunity we all have now in this sort of era, as we're slowly emerging out of the COVID-19 pandemic, although we're arguably still in it, to begin to think about what are the opportunities going forward and how we might take the lessons around health inequities that we learned during this pandemic, the inequitable access to health care, the very different kinds of impacts that this pandemic had on different populations, and the impact that this might have on the built environment going forward as a topic for today's panel. So we have a really, as Caitlin said, a terrific group of panelists. And what we're going to do is I'm going to ask each one to quickly present a little bit about themselves and the work of their organizations. And then we have a series of questions that I want to ask, and that we'll have a conversation afterward. And I also do encourage everyone who's online here to put any questions that you might have in the Q&A part of Zoom, and I will watch for your questions and we'll take those up as well. So with that, why don't I first turn it over to Giselle, and why don't you show your slides? Thank you.
Thank you so much, and good morning, afternoon, or evening, depending on where you're turning in from today. And thank you so much for the invitation, Caitlin and Mohammed, to join this incredibly impressive panel of speakers that you've put together today. It's really exciting. And then also for the organization for hosting a discussion on this really timely and critically important issue of how we can organize change towards health equity coming out of COVID-19. So just to say, I'm absolutely delighted to be here with you all. As Caitlin said, I'm Giselle Sabag, an architect, urban planner, and public health specialist working to improve urban health by design. And I have the pleasure of serving as the executive director of the International Society for Urban Health. For the past 20 years, the International Society for Urban Health has been the only global non-governmental organization dedicated to advancing our mission to work across all the different disciplines and sectors to address the urban determinants of health and health equity in order to attain a healthier future for all people in all communities worldwide. We are especially interested in the ways that we can translate the vast evidence that has been gathered over the last 2 decades or so of our organizational existence, thinking about the ways to build healthier neighborhoods and cities and turning it into action and impact for the residents that are living on the ground, regardless of their geography, their background, their age, or their income. So we put together a new organizational strategy recently for the next 3 to 5 years, which is now hyper-focused on translating all that excellent evidence that has been generated over the years into that action and impact for people who are really experiencing the differences in their health and well-being outcomes on the ground. So we're working on growing the community that we're working with first and foremost, and that we're communicating with. And primarily when we first started out, no one was talking about this idea of urban health. But so it was really focused on several different academics, primarily advancing different aspects of research on urban health. And now we're really trying to bring in the policymakers, the governments, the practitioners who are taking that knowledge that we now have about how we can create physical and social environments that support and improve health and well-being, to turning it into action in the form of policy or programs or projects that do impact the people living in cities and their communities. So we're also very focused on reaching those that are the most vulnerable, whose environments have led to health inequities and disparities when compared to others living within the same city, for example. And we really believe that this is critically important life-saving work, work that all built environment professionals, myself included, but I think probably all of you that are tuning in, Caitlin and Mohammed who are hosting, including architects, city and regional planners, engineers, all of us are doing every single day. Because I think one of the things that we all realized coming out of this pandemic is that we're all health equity professionals, and all of the decisions that we make that impact our urban environments, they're either promoting improved mental, physical, and social health in some way, or sometimes it's even hurting it, and it can perpetuate those existing systemic health inequities. So it's a really big responsibility, but it's a choice that we all have to make. And so, I think the idea of this today is bringing out some of those opportunities that we have coming out of the pandemic, And I just wanted to sort of ground the conversation a little bit in the way that we think from the ISUH perspective about thinking about the different factors that shape our health and well-being. So there's a multitude of ways that shape the social and physical environments that impact our health and well-being. And I generally think about these in three areas. So your genetics, those are, the things you're born with that you can't really change, your environment, and then your behavior. So those are choices that you might make about diet or exercise, smoking, drinking alcohol. And so what I like to think about in in a super positive light is that we now basically know, we have so much evidence to tell us that the leading drivers of death and disability across the world, things like heart disease and cancer and diabetes, it's determined, really, a lot of it is determined. You could even say it's almost entirely determined by your environment and your behavior. So your environment and behavior, the good news to me is that that's changeable. And so WHO, we have studies that link 23% directly to changeable factors in your environment, but many people, myself included, think the actual impact is much higher, maybe closer to 75 or 80%, when you add up all those indirect ways that environments change social and economic health determinants. So your behavior is really very highly influenced by your environment as well. It's not sort of your own choice that you make independently. I mean, just think about, for example, if you don't have a sidewalk, how could you possibly walk? So each of us in different ways, we really do have this tremendous amount of influence over how our environments impact our health and how our built environments can help or hurt our well-being, or facilitate social connections or activities that we know impact health. Next slide, and I will be going very quickly through these, just wanted to give you all an overview. So just to illustrate the idea of the ways that our neighborhood environments make an impact on our health, you're looking here at life expectancy differences within one city, within New York City. So in many cities across the world, the number one predictor of how long you're going to live is where you live. So this is New York, and so it's small, it's probably a little hard to see, but there's really dramatic differences of up to 10 or 20 years of life based on the neighborhood that you're in. So just to illustrate that a little bit, babies born just a few miles apart from each other, they might expect to live either 65 years of life or 90 years of life based on the places they spend their time, and whether those places support and promote or inhibit the health of the residents. Next slide, please. So just the overall point I wanted to make here is that critically, the decisions that make the biggest impact on our health and well-being, they come almost entirely from non-health actors. So these are, people like any built environment professionals. I think many of you are those types of people making decisions about built environments and about urban environments without necessarily considering or calculating the specific health effects of your design, development, or planning decision. So in effect, every person working to change our physical and social urban environment is a health worker. Next slide. So just to say, I really truly believe in the goal of ISUH is trying to put forward this idea that we can and we must do better now that we're armed with the knowledge of how we can reduce health inequities and disparities through changes in our social and physical environment. And this is a project that I got to work on in Columbia, and we really owe it to the future generations to do that. So back over to you, and thanks so much for having me again.
Thank you, Giselle. Charmaine.
Hello, everyone. I'd like to thank the Epidemic Urbanism Institute for inviting me and giving EDRA a chance to speak. I really like to thank Kathleen and Mohammed. Environmental Design Research Association, it was founded in 1960s. And it was founded by a group of professional practitioners, design practitioners, researchers, facility managers, students, and it's an organ association of mostly by architects, interior designer, landscape architects, urban designers, environmental psychologists, epidemiologists, and many other disciplines. So EDRA is a broad, it covers a broad spectrum. We have almost 25 knowledge network areas. For example, healthcare is one of the environment, a public space is one of the environment, children environment, workspace, residence, housing, international housing. So there are so many areas EDRA covers. EDRA organizes, promotes cutting edge design research, advocates for we always, it's the movement during 1960s, and all of our founders, they created EDRA so that we can reach out to the people and make sure that the human relationship, human behavior and the built environment, we reach out to the people and make sure that we are fulfilling their needs. So human needs and equity and inclusion was long established for last 53 years. Next slide. So here is the address mission. You can see the purpose to advocate and disseminate research, teaching, practice towards improving and understanding of the relationships among people, and missions to provide a collaborative, multidisciplinary community to connect theory, research, teaching, and as just mentioned, that equity, inclusion, and respect for all persons. It was embedded in his EDRA's missions from the beginning. Next slide. So EDRA, we have organizational structure. We have 9 committees. And among the 9 committees, the 4 committees are dedicated for this. For example, program committee is organizing the conference each year. They're also organizing it, any kind of like a webinar, any seminar, those are the things. Communication committee is also for social media posts, publishing. We are publishing proceedings each year. Members and partners and knowledge networks is one of the avenue we created so that we are not missing out any area of environmental design research. Within last 2 years, we have like researchers in practice and public spaces. Those are the 2 new knowledge network community we have. Student Affairs Committee, student engagement. EDRA from the beginning is all about educating the students, educating the professionals. So we have a huge committee and huge members from students, and they're becoming the new professionals, in their new career, and they're becoming professors, and they're sending their students. So there is a kind of like a chain of membership and retaining the membership. And one of the good part about when I like to mention that when we ask people why you come to EDRA, they said like, well, I can see my scholarly grandfather maybe, because my supervisor did his PhD from that professor, and that professor did his PhD from another professor. So there are like 4 or 5 tier of scholarly parenting. So that's a very interesting part of EDRA. Recognition and Award Committee is another committee. The way we recognize the work, we try to cover, we're trying our best to cover all the aspects of environmental design research. For example, we're providing Great Places Awards is becoming very popular. We are receiving like more than 100 applications. We are addressing the books, best book, best planning, place research, place design, and also very recently we launched the place art, which is also addressing the social inequity. I'll be more, and core certificate of research excellence. We established this one 7 or 8 years ago, and this is because this is mostly promoting and advocating all the research in practice, because the research in practice, they are not exactly doing their work the way academia is doing their work, and they're not exactly publishing in the journals, but we want to go through a review process. Peer reviewed process is also kind of like feeding them what they are doing, is it good or bad, and how to improve that. So those recognition and award committee is another big part of EDRA. Next slide. Here is a more detailed like how the EDRA organization works. Next slide. So for COVID-19 challenges, I would like to say like 2020, we had a conference in the month of April, and the entire world shut down in the March 18th, in the month of March. So as an board, we need to make a decision. Either we are going to have the conference or we are not going to have the conference. We just had like 2 weeks in our hand. And that was a very quick decision. We went for the virtual conference, which was very successful. It was not only successful, like all the participants, they presented and published. It's not only that, we opened up our EDRA, for example, Great Places Award ceremony, and people from remote area of the world, they were logging in. And we also provide discounted registration fees. And there was a discussion about the COVID-19. the COVID-19, April 7th or 6th, we started talking about how to accommodate COVID-19 scholarly. And definitely there were other challenges as well, because it was so unpredictable on that time, organizational, for example, we reduced the management cost, those are the things. But we dedicated 2 of our conferences, EDRA 53 and another one coming in Mexico, EDRA 54, both are focusing on health. EDRA 53 focused on all health in all design. EDRA 54, we are still thinking there is more need for doing the scholarly inquiry, focusing on health in global and local context. And it's focusing, if you read the call for proposals, and I will invite everybody to come to Mexico, and please come. So EDRA kind of feed the society, the professional and scholarly body through this conference, publishing proceedings, providing the education materials, organizing workshop. In the month of April, after the conference, I personally called out a think tank workshop focusing on COVID, and that was open to everybody, all the people from the world we invited. It was not only limited to the members only, and we discussed like what are the areas or topics, excuse me, we can focus on. Thank you. Next slide. So about health equity, health, as I said, like we are focusing on health, excuse me, but we are also focusing on equity. 2020 was the year that there was a movement about the equity inclusiveness, and we created the diversity officer on that year. We developed our policy. We launched, as I said, that it was a non-profit and non-political organization. So we launched the place art. We basically the art in the public places that talks about the place justice or social justice. Conference, we are providing free registration discounts all over to have more diversified population, more inclusiveness. EDRA 52 conference topic was dedicated for that. Thank you. The next slide is as I was mentioning, is Mexico. So as an organization, we took lots of strategies to accommodate COVID-19 or pandemic, post-pandemic as well. So I would say like, I cannot just focus like we focused on urban health, but we also focused on other areas, and from micro scale to macro scale, we are focusing on health and we're promoting. Thank you.
Thank you, Sharmeen. And next we'll hear from Sharon. Go ahead, Sharon.
Thanks, Tom. And thank you to Epidemic Urbanism, and thank you to everyone for tuning in today. It's a pleasure to be here in the virtual space with you. Sharon Rorty, I'm a senior program officer with the Robert Wood Johnson Foundation. And I just want to offer a disclaimer, and that is that I am neither an expert or a scholar. I'm an urban planner, an urban alchemist. What I really try to do is bring things together. I've been practicing for over 3.5 decades, and somehow I found myself landed in philanthropy. And I'm enjoying it, and I get to practice making those connections all the time. My work really focuses, like many of you, on the connections between the built environment, health, and equity. More and more, my work focuses on frontline and fence line communities. Next slide. The Robert Wood Johnson Foundation, for those of you who are not familiar with us, we are the largest philanthropy in the US focused on health and healthcare. We have long been working to build a culture of health rooted in equity that provides everyone with a fair and just opportunity to thrive. And when we say a culture of health, I noted in Giselle's introduction, she really talked a lot about what it takes to build a culture of health without using that phrase, perhaps. So I won't go over it, but hopefully you'll pick up that in the next minute or two as I speak. But to build this culture of health takes transformation. And transformation takes time and intentionality, especially around implementing equity in all that we do. And in pursuit of this transformation that we've been trying to make, the foundation is really leaning into its long history of being an evidence-based organization. Next slide. RWJF has invested in public health data infrastructure of the US for years, supporting efforts to provide communities with a suite of data resources and data sets that really focus on the drivers of health at the state, county, city, and census tract levels. These data resources have allowed communities to uncover health challenges, better target resources, and measure progress toward ensuring that everyone can achieve that good health. But the last couple of years, they've really shown us how much more needs to be done to advance health equity. COVID, climate change, the politics of hate, the spread of disinformation and misinformation, they're all coming together to exacerbate the health inequities and the disparities that we see. As a country, equity and well-being are not how we talk about health, and they haven't been emphasized in our data collection. To move the needle on health equity, that needs to change. So RWJF's work, our data work has evolved. It is evolving. We're trying to ensure that equity not only influences, but drives our data work, as well as how and what data needs to be collected. This work also emphasizes community involvement and input in shaping those data systems and the metrics. However, data alone is not going to reveal and create the momentum we need to address inequities. We need to help lift the voices of those in communities most affected to share their own stories and elevate their community-driven solutions. Now, in short, we really have to shift the power to those frontline and fence-line communities. That's how we're going to get to equity. Next slide. So let me just quickly introduce you to my team at the Foundation. The work and mission of the Foundation's Global Ideas for US Solutions team is to look outside our borders for those stories and solutions that make connections, that help make sense of the data, right? As we seek to build a national culture of health, we believe there is much to learn across geographies and income levels where people face similar health challenges. We've seen that in COVID. We've seen where people we had to come up with solutions quickly. So we had to look all across the world for solutions. What's working, what's not. And by looking beyond our borders for inspiration and practical solutions, we can uncover new ways to advance health in communities across the US. It's about bringing those ideas back in and sharing them with everyone. To gather these stories and insights, our team is looking around the world to understand how countries and cities outside the US are tackling health, equity, and climate change. How to connect sustainability and equity to matters of health and well-being. We're working with leaders and local communities to bring sustainable and equitable development lessons to the US. And we're doing this in ways that center the importance of equity-driven and community-engaged solutions. It's not the afterthought, it's how do they center it. We're actively exploring how models, policies, and approaches, like for example, on shared governance, that have worked in other cities and countries, how can they be adapted in the United States to advance health equity and build a national culture of health? So with that, back to you, Tom, and thank you.
Great. Thank you, Sharon. And then finally, Alan, go ahead.
Oh, thanks very much, Tom. It's a pleasure to be here. Caitlin, thank you very much as well. And of course, to Mohammed for the invitation. I'll spend just a couple of minutes talking about the Nova Institute for Health of People, Places, and Planet. It was founded in 2007 by Brian and Sue Berman. And Sue had wanted to be here today, but had other commitments. So I'm sort of standing in her stead. I'm a fellow there. I've been so for about almost 3 years. In fact, my position there was just before the pandemic hit. So I'll tell you a little bit about what they do. Thanks, Caitlin. So it's sort of divided into 4 different pathways, if you will, that all intertwine. The theme here so far from all the speakers that have presented is the idea of interconnected narratives, stories, research, data, facts, and policies and practices. And there's no different in the way that the Institute runs. You have scholars and fellows that work together as a network to integrate the types of material that we're discussing here today. We have forums and annual meetings called campfires that are smaller versions. And then we have an annual conference where we bring together many of the themes that have been discussed here today. Then we have demonstration projects, which is original research conducted by the scholars and fellows that explore, again, some of these very topics. Because I think, Giselle really said it so beautifully that if you're involved in anything to do with architecture, planning, design, you are in fact a public health worker, and you're influencing health at the scale of the person, the place, and the planet. And all of those, of course, are interconnected. And then finally, there's the outreach arm, which, again, takes us to the themes that have been discussed so far, which is what are the stories of people that we refer to as marginalized, that we refer to as disadvantaged. They have incredible and inspiring stories, and they need to be elevated so that you're not just sort of approaching groups without attending to their total lived experiences and everything that they can teach researchers and academics, which will ultimately inform policy. So those, thanks, Caitlin. And then it gets sort of broken down into common themes, which again have been discussed up to now: health, healing, and flourishing. And one point I will make on this is that we approach things from the perspective of vitality and flourishing. Of course, you want the absence of disease, we all know that, but you want the presence of flourishing and vitality so that everyone has equal opportunity to flourish during their time on this planet. Food and nutrition is a big part of this. So when we look at the scale and the heat map, we'll call it, that Giselle put up, food and nutrition play a big role, including the way that the built environment and the marketing practices of corporations influence the food decisions that are made. So you have food deserts, which we can talk about, and I'm looking forward to engaging in some of this conversation as we go. But then you also have the presence of targeted marketing, billboards, ads, everything that certain communities don't have to deal with and others do. And then the social determined nature and planetary health is an obvious. I'm sure we'll get into some discussions of green space and natural environments as they help to determine health outcomes, and the interwoven social determinants, which we've already heard so much about, and we can continue that conversation together. Art and creativity is a big part, and including artisans and creatives as part of the input into this. I think it really, you're missing a big chunk of discourse if you only have scholars and fellows talking at one another, and you exclude artisans and creatives who are so good at holding a mirror up to society. So that's why they're a big part of that. And then, of course, research and evidence as well. Thank you, Caitlin. The social determinants is a big part. I mean, again, I don't need to go over this again because the other speakers have eloquently described it. We're here to deal and discuss some of these factors as they relate to the built environment, including racism, economic injustice, and misinformation, which Sharon already mentioned. I think that's something that often gets overlooked. And then unequal access to clean air, and all these upstream drivers that I mentioned in terms of marketing, because Tom said that the pandemic unmasked the inequities that already existed. It also demonstrated that non-communicable diseases, diabetes, cardiovascular disease, that are already carried and shouldered, that burden is shouldered by marginalized communities to begin with before the pandemic. But how does that happen? And we have to discuss the way the built environment influences outcomes through marketing and how it differs from community to community. Thank you, Caitlin. Mission Thrive is another example of what the Nova Institute has done and continues to do. And this is getting into the community and exploring how food choices can be made in a very healthy way at the community level. In fact, one of the studies that sat underneath the Mission Thrive project went into a predominantly African-American high school in inner city Baltimore and taught the students how to eat differently, how to think about food differently. And the outcomes were really, really wonderful. And those were published in a research study, which is on the website. Thank you. Green Road is another example of the way the Institute has tried to incorporate nature and natural environments into the discussions. This particular project, and I welcome you to go to the Nova Institute's website and have a look at the little video there. which described the research project involving war veterans with PTSD or TBI or traumatic brain injury, and showed the outcomes related to walking through green environments versus the urban built environment in terms of mental health outcomes. And again, there's been research publications as a result. And I'm just giving you a slight, just some examples for food for thought and to encourage some discussion as we go. Thank you. The integration hub, we already know that hubs are really a wonderful way to get thinking, integrated ideas for new research, to engage stakeholders, and also, as we mentioned, to have a place where stories that don't normally get elevated have a place where they can, be explored and be brought to life. And so the Integration Hub at the Nova Institute, which is going to bring together so many aspects of what we're discussing here in various forms of discussions about health and equity, will be there. We're aiming to make this a fire starter. I'm going to be helping to lead that project, and that will be up and running by the end of the year in time for our NOVA conference, which will explore many. It's an annual conference, and it'll explore many of the topics that we're talking about today. Thank you. Some of my own personal areas, Caitlin in her kind introduction, mentioned the secret life of your microbiome, which is really, in terms of the built environment, the microbiome is a really important topic for us to discuss. Tom and Mohammed, we mentioned earlier the connections between the risks, and obviously that's what COVID showed, the risks of contagion, the negative aspects, but there's also a good aspect to this too. And now you have large research groups getting together to talk about equity in terms of microbiome, to the point where it's become a really important issue to talk about, and where it intersects with food and nutrition and biological outcomes related to non-communicable diseases as it relates to the built environment. You see over there, the fast food and socioeconomic associations. Well, that's having a biological effect right in the body. The image that Giselle put up towards the end of her slides, you had the children out there, their hands in the dirt, they're gardening. I mean, they are making contact with microbes that we now know offer a health benefit, in addition to all the psychological benefits of being connected to nature. But in terms of the microbiota, there is that flip side to the story where it's not all dangerous. And you've got researchers like Jake Robinson. I would encourage you to look up that name, Jake M. Robinson, and look at all the incredible research that's being done with regard to the built environment and microbiome equity. And when I say built environment, I mean internal, within the building, and also within urban environments in the outdoors. There's been amazing new research on green walls, for example, in internal environments within buildings, influencing microbes on the body in a beneficial way. Sorry, that last one too. Thanks, Caitlin. And then just really briefly, just one back if you can, Caitlin, thanks. And just really briefly, again, if we can get some discussion going about my passion at some point along the line, and it's just this notion about, because we're here to talk about the COVID pandemic, and you see research like that, like restaurant dining, it's low-income communities that are consuming the unhealthiest of foods. And there are reasons behind that, economic forces that push down on marginalized communities. And then also there's this really cool, you may be familiar with this already, I'm sure many people on this call today are, and this new and emerging 330-300 green space rule. And that's that ideally people should have at least a view to 3 trees out of their window, and then also have 30% canopy cover within an urban environment, and then also live less than 300 meters away from a park. And research is starting to back this up. It's actually kind of cool. This particular study that you see up in front of you, the one that was least connected was the 3 trees out of your window. There is some research showing that that's been connected to mental health and COVID, so that's why that was included. But in the end, it was the 30% canopy cover that had the strongest area of research, at least in Barcelona in this study. So I just wanted to throw that out there. And then I'll say thanks to Brian and Sue. And thank you, Caitlin, for handling the slides. I really appreciate it. Happy to talk more about NOVA at some point.
Great. Thank you, Alan. Well, you've all touched on how the COVID pandemic has affected the work of your organizations, but I thought we also would expand it a little bit to sort of talk initially about what changes do you see in health practices going forward as a result of this? And some of you have begun to discuss that, but what do you see from your own organization's perspectives, a kind of changing way of practice? For example, one of the things we saw with this pandemic was the rise in the use of telemedicine. And we also saw that there was inequities in access to that many people don't have access to the internet, don't have digital devices. And so one of the things actually that I'm working on here in the Twin Cities is about digital equity related to health. How do we enable everybody to have access to health providers? But what other ideas and practices are you seeing out there that is changing as a result of the pandemic?
Sure.
Go ahead.
I'll go. I'll break the ice here.
Sure, great.
I think one of the changes that we're seeing, or we have seen, and I hope it continues, I really do, was the willingness in the part of city leaders to experiment, to try things, to, in some cases, to fail forward, right? I mean, for years I've been working in, before even I landed at the foundation, I worked in community building and transportation, and trying to get communities to sort of create these bikeable, walkable communities and more public spaces. And it's been a long road. I mean, things have changed, but it's been a really long road, no pun intended, right? But here we come into the pandemic, and the pandemic, COVID's been awful. But suddenly, because of the need to have people connect, to get at least some time outside their homes, to connect with other people, mayors who and chambers of commerce that were unwilling to create more walkable, pedestrian-friendly cities, bikeable places, open up public spaces, some that were parks and some, parking lots behind, town halls, and create public spaces. All of a sudden, they were willing to do it because it came out of need. So that's something to get behind, and that again, it doesn't always work. But that they were willing to try things, I think was really big. And, we do call that sometimes, taking those risks and sometimes failing forward. It doesn't work, try something else. It came out of necessity. We see some of those things rolling back. And, sometimes, hey, that failing, we tried it, that didn't work in that space, but hopefully it doesn't all roll back, that we get to keep those things, because that's making that connection about the built environment and health, and not only the physical health, but that need to connect with other people that we so have, that well-being part, the mental health that Alan was even showing, the connection between green spaces and really connection between people and people is so important as part of our work.
Yeah, great point, Sharon. Others?
I guess go ahead.
Please go ahead.
I was just going to expand a little bit on what Sharon was saying, just to say that I think finally, I mean, of course, there are so many horrible things that have come out of this, but there are some sort of maybe positive things that people have seen. And as Sharon said, I think that's, allowed some leaders certainly to do things that they weren't doing before. But also, I kind of feel like there's this collective understanding or visibility for the work that we're all doing here to get on this panel. We're all sort of going towards the same aims in terms of putting a light on the ways that our environments do impact health, and also the inequities that people experience. And we all experienced it sort of together and in different ways, depending on where we live. But I do feel like it's certainly given a lot more visibility to the importance of that, because people lived through that. And I think, to Sharon's point, there's so much around creating public spaces where people can meet and sit and, actually have some social interaction. I mean, the impacts of isolation from the pandemic have been profound. Similarly with mental health, all the exposure to nature that Sharon was mentioning, but also opportunities to be outside. And I do hope, I think, to Sharon's point, there's a willingness, and some is rolling back in certain cities like New York. But across the world, I think we saw different reactions. And I do hope that some of these governments have an opportunity to learn from this as well, because some places like Spain, for example, they locked their children inside for 4 months, I mean, really, and there's huge effects to that. And even though it's an awful thing that happened, I'm really hoping that we can see how important these aspects really are. Being able to reach places where we can have interaction, getting some exposure to not just nature, but also to sunshine, opportunities for playing together, and the massive health benefits that come with that. So I just think it sort of put a lens on the importance of these issues, because I feel for a long time that these were completely ignored issues, especially in light of, really important priority areas in terms of health. But this, the way we live and the upstream factors, I think now we're sort of seeing the downstream effects of not doing anything about that. So I'm hoping people can learn as well.
Great.
Thank you.
Charmaine, go ahead.
Yes, I would like to talk about two things. One is about the healthcare delivery. So definitely, pandemic has opened a completely new avenue for healthcare delivery, telemedicine. Also, we know that during the emergency time, all the hospitals, all the healthcare facilities were accommodating the surge capacity. They were trying their best to accommodate all the pandemic patients. It's also kind of like opened the eyes, like how unprepared the entire world is. And from there, if I just focus on healthcare facility design and research, now we see there is a huge surge of ambulatory surgery care. For example, people now, instead of creating a mega hospital or big size building, now we are breaking into small pieces. We are making into and also the facilities, for example, telemedicine is excellent, and it will definitely reach out to the people who are in a rural area who even may not be able to communicate. It will create the awareness of health and everything. So telemedicine is definitely one way. There is a researcher I was talking, and she presented in EDRA, and she's doing the research on, for example, the marketplace, Walmart or CVS in the United States, or like a community store, C-store in any part of the world, how that C-store, because people go to that store after their home, they go to that third place, C-store, and how they can tweak the C-store into a mini clinic or telemedicine. So there will be a huge, in the healthcare delivery, there is a huge shuffling going on. As a designer, it doesn't matter, you're an architect, interior designer, or engineers. Now we are very concerned. It used to be, for example, fire code. We used to measure the capacity based on the fire code, right? In this restaurant, you will see like 99 people can accommodate in this space at a time. And that demarcation was from fire code. And now world will change, not only with the fire code, but also like a ventilation. So this is space, the way we are designing, doesn't matter natural ventilation or artificial ventilation. This space at a time can accommodate 33 people. So that is reducing the number. So de-densification it's in its rise, and huge research. We need more designers and researchers because we will overdo it. Definitely, we are traumatized. It's a post-traumatic syndrome we are going through, the entire design research discipline. So we'll overdo it. We'll make it bigger spaces, and maybe then we will come to know like, okay, there is underutilization of the spaces, and then we will find out optimization. So that is one of the aspects of healthcare. If we just focused on the healthcare facility design. Now coming back to the public places, I mean, other building types or city or community design type. And I would echo Sharon and Gesley that, yes, this is, I personally, as a researcher, I would like to say there are two types of disability. When we are talking about health equity, one is a person, individual disability, for example, that person cannot walk or see, or any other, even mental disability. But another one is a space disability, place disability. There are places, that place cannot give you the sunshine, that place cannot give you the fresh air. That means that place has the disability or kind of like disparity. It can't provide the basic human need of health design. If we go back to the history of our city planning and city design in India or in China or in South America, all those old cities they designed, health was a big issue on that time. Now we are becoming, I'm sorry to say, and unfortunately, we are becoming so much money driven. It might sound very sad, but pandemic to some extent is bringing a little bit of blessings to the entire world, that now we are not going to run for that much of money. We'll create a better, healthy places. And that is the thing, at least we all are looking forward.
Sure. Great. Thank you, Charmaine. Go ahead, Alan.
Thank you. I just wanted to echo, I'm really glad, Charmaine, that you brought up post-traumatic stress, because the corollary is post-traumatic growth. And there's been some research on that post-pandemic. And so what are the assets at the individual and community level that might facilitate that? And so at the Nova Institute, just going back to the original question about, what are some of the things that you've been looking at? We're currently looking at the factors. How does post-traumatic growth occur at scale beyond the individual? There's been a fair amount of research that's talked about it at the individual level, but there's also some emerging research to kind of querying, well, how does it happen at the larger scales? And then the other thing that I wanted to just briefly mention, going back, to your own work, Tom, and that is that I think the Institute has really sort of sat bolt upright with regard to the spread of mis and disinformation that Sharon mentioned in her discussion as well. Because, we all, of course, mis and disinformation is not new. It's been around since as long as there's been communication. But the scale at which and the rapid nature of which it is spread is unprecedented. And obviously, we all know about, what has happened during the pandemic with that and the danger that it presents. And so when you're trying to effectively communicate health promoting communication, I think it's really important. And we've learned how important it is in seeking counsel from journalists. The Institute is bringing on fellows in journalism to help with that process. And that really is a byproduct of what has happened during the pandemic. And then, what can we do from a solutions perspective, an educational thing. And just lastly, I really appreciate, Charmaine, you as well, just being candidly honest about the fact that certain segments, sectors, shall I say, have promoted handsomely in this regard. And that takes me back to my pet, which is the fast food and ultra processed food businesses that have profited handsomely, and most often on the backs of marginalized communities during the pandemic. And there's some good research on this. Thank you.
Yeah, great. I'd also like to explore some of the impacts this might have in the built environment. I live across the street from a middle school, and one of the things that was really fascinating to me during the pandemic is how they converted their parking lot into a food distribution center, where they were using the school buses to move healthy foods to their student population who were food insecure. And so, this idea that during the pandemic, there were new ways of using physical spaces, in this case, a parking lot. But what other examples have you seen and or that you are thinking about in terms of possibilities for a kind of post-pandemic built environment that might be healthier and might be different from the one we had prior to the pandemic? Any thoughts about that?
Well, I think that Sharon has much to say about this, and she touched on it earlier, but just to sort of start out with this idea that the streets sort of were reclaimed, I think, in a lot of cases by the people who lived in those communities. And, as Sharon was talking about earlier, we've been trying to do that for such a long time, and it was just impossible. And then, because either people left or out of necessity, finally, that was something that we saw. That, to me, that sort of reclaiming of space for the people who actually live, and so everybody can use it, not just people who can drive a car, which obviously excludes so many, younger kids, older people, and everyone in between. That, I think, was really amazing. But I guess something that I realized that I'm really sort of hoping for, even if I didn't see it maybe enough, but it's something that I felt like would have been really important, was this idea, if there is one, of a really mixed, like a very mixed income neighborhood or community. And it's not just income, but I think it starts with housing, actually. So having opportunities where everyone can work and live in the same neighborhood together, because we needed those essential workers so much. And in so many cases, for many, many reasons, I think overcrowding and labor conditions most especially, but for many reasons, they had to commute for hours many times to get to the places that the ones of us that stayed, which I lived through almost all the pandemic in New York City, and most of my neighborhood left. So there were a few of us that were left, and we still needed the amenities and services that the neighborhood provided, right? But it was hard for people to continue coming to work and being exposed, and it was difficult for them to provide. Wouldn't it have been incredible if we all could have walked or biked to our places of work? If the people who weren't privileged enough to work from their home office, if they were able to get to their job and provide, the community, all of us, with all of the variety of amenities that we need. So I'm sort of thinking of, I know that we talk a lot about the 15-minute city. I was just at this meeting a week or two ago in Northwest Spain in Galicia, where every single thing that you could possibly think of that you needed was in a 3-minute walk. So every time you looked for something around you, it was 3 minutes. So we were making jokes that it was the 3-minute city. I mean, the whole center is pedestrianized. So there's a lot of lessons to learn from that. But I just am sort of dreaming of this future that I haven't completely seen, but I feel like there's the beginning of it in the post-pandemic world, of a place where we can all live together, because there's just so many benefits in terms of the physical activity opportunities, the social interactions, the interactions between young people and older people, the green space opportunities. Everybody has the same, opportunity for the environments that we live in, physical and social, to support and promote our health and well-being. So that helps us so much with those inequities. So maybe it's just a dream, but that's sort of what I'm hoping to see some of this manifest into.
A nice dream. Thank you. Good. Sharon, go ahead.
So I'll build a little bit on that, and even to Alan's phrase, sort of the post-traumatic growth. So a lot of bad happened, and hopefully a lot of awareness happened from the bad. Exposing the inequities that Giselle was talking about too. One of the areas that we're investing, a grant we have with the Concrete Design Initiative, KDI, out of LA, and they work globally, is to look at public transportation. Public transportation in the cities that have, extensive public transportation systems was really built sort of, in the States at least, post World War II. And it was designed for men commuting, from suburbs, because that's where our development was, into, the business district, right? And we haven't changed that model. And, along with that model was that there was a parent, a mom, usually at home taking care of the children. So, we continue to invest in these transportation systems that aren't serving all people. So with KDI, we're looking around the world at transportation systems and gender inequities. If we want to, we want a new world, invest in new kind of infrastructure, we also have to think differently and plan differently. Who are the people that need to get around, and where are they going? They're not just coming from the suburbs into a central business district. If anything, we've seen a lot of CBDs, that's not where the action's happening. It's dispersed, but it's been dispersed for a long time. Whether it's women or whoever taking care of the children, they need to get to the daycare centers. They need to get to take care of their elder parents. They need to stop off at the food stores, whatever. So we have to have a transportation system that is designed for all people of all abilities, to get to all the places that they're going, not just a linear system. So, I'd say that goes towards this post-traumatic growth. There's opportunities for it. We've got to plan. There's the physical infrastructure, and then there's the soft infrastructure. The soft part of that is planning, and then the policies that go along with it, that direct those investments, that look at gender inequities, that start solving for these problems. And along with it, while we're doing it, it's not just the virus transmission. We're living in a world where climate change is no longer something of the future, it's now. So if we're trying to decarbonize, get more people out of their cars, out of the single occupancy vehicles, then we need to have a transportation system that really serves all people too. These are all opportunities for growth and doing things more equitably.
That's great. Thank you, Sharon. Yes, I've been watching the rise of new kinds of building types. There's this thing called the Neighborhood Clubhouse, which is starting to emerge, which is a sort of like the equivalent of like the corner store, but it has childcare, access to healthy food, places to access technology, places to meet. In other words, it's a kind of new hybrid for people who might be working at home but don't want to work or can't work at home, but don't want to commute into a central business district. So we may see these new emergent kinds of facilities coming out of this. Other thoughts? Yes. Charmaine, go ahead.
Okay, thank you. A nice point. All of you mentioned a couple of points I would like to add on. For example, new programming, new facilities will be evolving. Why? Because our daily routine has changed. We used to go to office. Now we have a home office. Almost every household has a home office. And we also learned that working from home is not also mentally or productive wise very healthy. So there is a part of us will be at home and then part of us will be in the office maybe. And it is also opening some opportunities for people who never thought that they could work, but now they have started working, even though there is a huge labor shortage in the United States. We are trying our best to make energy efficient, less traveling, less car. If you want to purchase a car, there is no car in the market. So people are purchasing so many cars right now. So what I wanted to say, in every level, in every part of the world, I'm from Bangladesh, by the way. I'm from Bangladesh, and that is the most densest, crowded country in the world. I am from the city, which is 400 years old. And there is a street where the density, like the people are living, it's a 7 feet by 10 feet of space. People are living, 5 people are living over there. So I have seen that world and I have seen this world. I kind of like blessed with seeing both sides. Changes are everywhere. Now, some of the changes will be good, some may not be. Now, focusing on home environment, there is a huge renovation going on, not only for the healthcare providers who are coming from the hospitals, but also even for the marginalized people. Now, they just don't want to rent an apartment without any veranda. Everybody is looking for apartments, which we have neglected to creating a veranda for a long period of time. People are having garden because they have learned, or they are learning that having a garden, planting, it's not only providing you healthy food, but it is also providing you exercise when you are compartmentalized into a small space in your home. So that's kind of like if we talk about the housing is a big important because 70% of the built environment is a housing environment. And we need to really focus on that part. Institutions, industries, school, those are infrastructure. Those are like rest of the 30%. Coming back.
Go ahead. No, go ahead, Charmaine.
Okay. Coming back to the dream of Giselle is having the Spain, like we will have everything within 3 minutes walking distance. That means that a space is very densified. So we may have to have a satellite densified villages kind of like, but we cannot have like all the people, which is in Dhaka, you will get everything within 1 minute of walking distance. But there is no breathing space. So we need to find out where is the balancing. There will be some demolition as well. Demolitions happened in past after the pandemic. There will be some demolitions in the crowded cities as well. Also, the cities, for example, Houston, I was in Houston. If you want to go to the office, you have to drive 1 or 1.5 hours. And that is also, we are reducing. We are going to the office 2 days and we're working from home for 3 days. So there is a change in our activities, and definitely that change will bring to the built environment.
Great. You know, there's a question from the Q&A, which I thought I'd bring up because it really leads us to the next area of conversation I wanted to have, which is, you know, how health delivery itself is changing. This question goes, I thought that one of the things we learned during the past couple of years is how much seemingly separated life segments are so much connected together. It's so evident that the pandemic impact starts from the hospital and healthcare setting then quickly links to food, nutrition, to school, learning, to workplace, productivity, public safety, political stability. So this is Henry Chow says, the challenge of equity is beyond health. While health might be the quickest indicator, are there organizations threading all of these areas together that provide us with a new set of life paradigms moving forward? This brings to mind a point that Michael Osterholm, who studies pandemics at our university, said, which is that in a pandemic, what's most important is not just access to a healthcare setting, but knowing your neighbors. And having a community around you is as important as having access to a hospital. So what are your thoughts about the impact on health delivery, and how is healthcare and health more broadly changing as a result of the pandemic? Any thoughts about that?
I personally think the food industry has changed a lot.
Mm-hmm.
People has become more and more concerned now. The home delivery, because of this pandemic, we have learned like there is a chance that we can have the home delivery. But not only we're looking for quick grab, unhealthy snacking or unhealthy burger stand in our neighborhood. Now we are looking for, okay, we can have a healthy food which can be delivered to our door. So that's I think another area. The food industry is changing, and other
Mm-hmm.
aspects I would like to open for other speakers.
Well, I sound like a broken record all the time. So I, of course, am thinking about, hopefully sort of embedding healthcare into the communities that we live. I'm hoping that that's something that people are more open to. They see the benefit of. I think there was a clear ROI when that was, something that was able to happen through the pandemic because of necessity. So I'm hoping that that sticks around and we can continue that. Obviously, there's a long model and history of that around the world. So I'm hoping that we can continue to see that. But then also, I think the talks, I think you were mentioning, Sharmeen, a lot about the telemedicine idea. For people who have access to telemedicine, I think it can be something pretty incredible. In combination with these upstream factors in our social and physical environments, and really getting primary healthcare or prevention in advance, so hopefully we don't need to actually consult doctors when we're sick that often. But when we do have to, telemedicine I think can be a pretty amazing thing. And what I was thinking specifically about though is the rise in therapy, basically. So all of the mental health issues that we've been seeing, I feel like that's something that we really rose throughout the pandemic. And I think it's sticking around for good reason, but it's so important. And stigmas, I think, that we've always had about mental health, some of the tele-delivery models are actually helping to break those down so that, there isn't a stigma of being seen or going into a physical place actually, but having the ability to consult with someone and get some, having a chance to talk to someone in the privacy of your own home. So that part of telemedicine and delivery, I think, has really changed. And I think it's very important. And I hope that's something that we continue to see.
So I'm going to come in with a yes, and if that's okay, Tom, here. So yes, and we've also seen through COVID, through the pandemic, that there's a digital divide. So yes, telemed can open up opportunities for people, particularly people that live, say, in rural areas where the doctors and the health clinics are not that available. But we also know that some of those same places are places that don't have access to broadband. It may not exist. It's the connections they do have are poor. They don't have the equipment for the telemed. And also, sort of just the acuity with doing what we're doing right now, talking to each other in a virtual space, right? So yes, it's good. It may open up more opportunities, maybe more appointments, but we have to be really, really careful about the digital divide and sort of what we've been talking about too in different aspects, sort of that need to connect with people in 3D, right? So I worry about that. And I think we have to think about that as we go forward too. But the healthcare industry, I mean, one of the things I'm getting pretty excited about is this organization, Healthcare Without Harm, that's working with the healthcare industry throughout the world to decarbonize healthcare. The hospitals, the institutions, to really look at their footprint in the world, and to say we can do better, and to do it as a model for other sectors. And it's not just, sort of the decarbonization, which is huge, but also how their footprint in communities, how they work with communities, how they work with local food purveyors, or if they work with it, do they just work with the big, sort of food delivery companies? So Healthcare Without Harm is saying, how can we really create better connections with the local community, which helps them to reduce their footprint in the energy sector, but maybe increase their footprint in the way they employ and relate to the communities that are surrounding them, which is really so important. And again, it's sort of delivering health in a whole different way. We have to think about the healthcare industry beyond, I need a checkup, I have a fever, I have, whatever health symptom is. So, they're a huge industry with a huge impact, and they can really be the model for so many other sectors.
Alan, go ahead.
Yeah, thanks, Tom. In the United Kingdom, where everyone has equal access to healthcare, for the most part, there's obviously, some issues with that as well in certain communities, but social prescribing is now post-pandemic become, it's on the rise. And so I think that hasn't really hit the United States the way that it should. We started our conversation with Giselle pointing out what the WHO says, maybe the factor regarding to contributions towards mortality. It's likely, I agree with Giselle, I think it's up towards 70% if you look at modifiable risk factors. But the idea is we need to start engaging more in social prescribing, and that can be done at the local level and providing resources to parks, to social services, because the model that Giselle presented was very useful for all of us here today. And that sort of concentric rings of health and what determines it. And I agree with Henry that health is not the only determinant of whether or not there's equality or equity, not by a long shot. But if you start to look at other factors around the word health, like vitality, like flourishing, like opportunity, then you're starting to talk more about whether it's not whether or not you have a certain disease or don't. It's whether or not you can reach your potential on this planet during your time. And that requires opportunity. And that takes us back to Giselle's dream, because we should all have that same opportunity. And there are markers for that. And that's why I like to look towards markers of flourishing. Because it's a little different. You're talking about with flourishing, and Tyler Vanderweel out of Harvard has done tremendous research. They're doing a global flourishing study right now, and they're looking at all the factors that pertain as best they can. There's 40 questions that they have. What across the world increases the odds that you are going to flourish in your life? And the closer we get to that, the more we're going to be able to pull the onion layers back and determine those factors, including the many that relate to the built environment. So I would encourage people to look at the Global Flourishing Study. Those questions are online. You can see the 40 questions that they use in order to evaluate that. And it's an ongoing huge project right now. Hopefully we'll have a lot more answers.
Do you all see a shift in investment too? I mean, the United States spends about 80% of its health dollars on health care and only about 20% on prevention, while Europe, it's almost the flip. Do you see this pandemic having a shift in what we invest in, and that there may be more investment in upstream health rather than all of this focus on the illness part of healthcare? Do you see any shift going on? Any evidence of that?
Well, I mean, our spending on health in the US is just not sustainable.
Right.
It just isn't. So I think almost the answer to your question, Tom, is that there has to be. But has there been a huge shift? There's forces working against us. When we come up and try to create a healthcare system that really gets us beyond the market. Still, I have hope. And I think when seeing the price and the cost of healthcare and what it does, the harm it ravages across populations, I think there's a greater awareness. I think when we say the social determinants of health, the social and physical determinants of health now, people get it more. The map that Giselle showed in the beginning of this presentation, just showing, the neighborhoods, the census level tract information across New York City. People have seen that more and more, and I think are waking up to the fact that we have to do things differently. So has there been a huge shift? I can't say dollars wise yet, but I think there's an awareness, and I think that I want to hope that we're on the edge of change.
Great.
I feel I should give credit for the slide that I showed in the beginning, which shows New York. Robert Wood Johnson, Sharon's organization, funded that project and supported it. So I'm getting a lot of credit for it, but actually it was all thanks to Sharon's organization. So I just wanted to give proper credit. But if I could just sort of respond to the last comments from Alan and Sharon for a moment, just to absolutely agree, I think, on all of these aspects. I want to put a finer point on some of it. In the US, I mean, I'm now living in Europe, so it's an interesting experience to see. And I knew that the UK had been doing social prescribing for a while. So it's really interesting to see that that's increased actually since the pandemic. And great, since I think we all agree that connecting with people in 3D, as Sharon said, is so important in so many ways and has such a profound impact. And I think it's been very undervalued for a long time. In the US, though, we don't have a pay for performance model. We have people, the incentives are actually around people getting sicker. And, even if a doctor is able to heal what you have going on right at that moment, there's absolutely no incentive to put them into an environment that's going to make them healthier in the long run. So, as I think there's a cautious, it's a little bit, I mean, we have to be a little bit skeptical because right now the system just does not incentivize creating any upstream improvements in the way that, our environments are improving or impacting our health. And just then to go back to the other point that was made around telemedicine, absolutely agree with the comments, Sharon. Just was thinking also, though, that, for a while, and I don't know how it is now, I don't know how the pandemic has impacted it, it may have, but for a while around the world, especially in low and middle income countries that didn't have universal access to internet or high-speed Wi-Fi or broadband, there was cell phone usage that was being used for a huge number of things like banking, and I think also for health. So just to say that when I'm thinking about, let's say, you being able to connect with a therapist in a virtual way, even though I think 3D always is better for a huge number of reasons, maybe it still could be a stopgap or another opportunity to access some type of mental health care for people who don't have it, when most people actually do have some sort of cell phone access.
Just really quick on that as well. Yeah. There's been a rise in references to the commercial determinants of health, which I'm glad to see, because as we started off saying, the pandemic has really unmasked the fact that it's the NCDs that are related to mortality, related to hospitalizations, related to severity. So the sooner that we start discussing the commercial determinants of health in a more robust way, the better off we'll be, I think.
Great. Well, in the final 5 minutes or so that we have, I did want to also just ask the question of what do we need to do to get ready for the next pandemic? I know that there's conversations going on around this topic in places like Singapore and other countries where they're starting to anticipate what are the lessons we've learned from this pandemic and how do we prevent the same kinds of problems the next time? Any thoughts about what either the US or the world needs to be doing to mitigate or even prevent the next pandemic? Any thoughts about that?
I might be in the minority here, I'm not quite sure, but I actually think so much of it goes back to addressing the environmental impacts that lead to this, greater climate change, that we're seeing the effects of those environmental disasters, political conflicts and crises that we continue to see in, major health implications from, and then ultimately that's going to continue this drive of new infectious diseases. We know that new zoonoses are created as climate change continues to worsen. Until we address those underlying environmental factors, we're going to continue to have this problem over and over. So again, I really think that it starts with the prevention and the upstream determinants, but we at the same time have to be addressing some of those environmental issues that frankly we're still ignoring, and I don't really see a good way out of it. Not to be a downer at the last moment, but
that's okay. That's good. Yeah. Any other thoughts about that upstream prevention?
I just like to
go ahead, Charmaine, and then Sharon.
So I would like to say one line that we are learning about the COVID but we are still not prepared for the airborne infection. And that's make me like a goosebump, that kind of like I'm feared about if we are having airborne infection, how to prevent that, and is our built environment is ready for that? We are not.
Right. Sharon, did you want to?
Yeah, so I agree both with Sherman and Giselle very much. And I just want to add to, in the beginning, when I was introducing the foundation, I kind of leaned into our history of being an evidence-based organization. And of course, we're not the only organization that collects evidence and supports evidence, but how important that is. And, you know, as we prepare, whether it's, you know, this pandemic that we're still in, or the next pandemic, or, you know, I'll call climate change the pandemic we're already in, it's impossible to fix what isn't measured. And we can do a better job of this. And if we're going to get at equity, we have to think about what are the metrics we've been using and what are we leaving out? What are the gaps? Because we certainly saw that in COVID, you know, what we're measuring, who's doing the measuring, how it's validated those measures, right? If we're not doing those things, we're not asking questions around sort of the metrics that we've been using and who's doing the measurement and what, you know, what value we extract out of that, then I fear that we'll be in the same boat going into any next pandemic, whether it's virus or environmental or however it's defined.
And we have an interesting point here from our audience. Antonio Carvalho talks about, suggests that new legislation to promote and enforce cross-ventilation in built environments as a basic requirement could be a good upstream contribution. That relates to some of what you were talking about, Charmaine, right?
Yes.
Yeah, right.
That was a huge miss this time. I mean, mega giant, easy, cheap opportunity, and almost everybody missed it for like more than a year. So totally agree.
One of the things that I've written about this topic for many years now, and one of the more controversial proposals I've made is that we have to rethink international air travel. That one of the fastest ways to move pandemics around the world is the speed with which we can now move and the lax way in which we handle people moving from one part of the world to another. That's been a very unpopular point of view, but I still think as we see how these pandemics spread, international air travel is a key component to it. So. Well, we have just a few more minutes. Any other thoughts you might have that we haven't touched on yet that you wanted to make before we sign off here?
I'd like to thank this panel organization, because one takeaway for me for EDRA would be, because we are a professional organization, we train and educate professionals, but it is also true that we are not producing the materials which can be directly linked to the public. So the takeaway for me, and I will definitely convey this to the board, that from now on, maybe we can have the conference of the researchers or whoever presenting their research or design, maybe having one line that can be translated with a picture or some kind of like communication, mass communication, which the public can implement in their life.
Mm-hmm. Right. And that gets to the question of how do we connect to the broader public about these issues, right? Yeah. Which your organizations in various ways are doing in remarkable ways, I think. So I think this is the inspiring work that you're doing, I think gives me, and I think probably everybody, hope that that this post-pandemic era that we're entering will be a shift in thinking about health and about the built environment and the diverse ways that it affects different people, and that equity has to be, I think, front and center on all of this. And I think that this kind of turn toward equity that I see in the philanthropic community is, I think, also really encouraging. With that, maybe we can wrap it up and thank all four of you for a really terrific discussion. And maybe I'll turn it back over to you, Caitlin.
Great. Thank you so much. I wanted to echo my thanks as well for this robust conversation. I always feel like we could go on much longer than we have time for. So thanks, Tom, and thanks so much to our panelists. And of course, thanks to everyone for being here. I know that there are so many constraints on our times these days, especially in this hybrid world. So again, thanks everyone for being here and joining in on this conversation. I just wanted to remind you all of the next conversation that we have coming up through the Epidemic Urbanism Initiative. Our session, Health Inequity and Architectural Practice, will be on Saturday, November 12th at noon. I encourage you to please register for this session using the bit.ly link on your screen, or if you have access to a mobile device, you can also use the QR code that you see there. The session will feature architects from our kind of global community and will be chaired by David Gloucester. And we really look forward to asking some of these really big questions to that group as well. So with that, again, just wanted to say thanks everyone, and we hope to see you again soon.
Thank you. Bye-bye.
Thank you.